Okay, so and the time is on. We're gonna start the last session today, and this session is complex PCI workshop session 4. Is mainly focused on the complex and high risk interventional procedure. This is a so important practical issue in our daily PCI practice. I'm D.W. Park and the co-moderator Dr. Kao, and we invited already mentioned worldwide famous physician in the Asian Pacific region. So, and I'm gonna introduce the first speaker, and the first case is a very complex scenario, ischemic cardiomyopathy with a multivessel disease, and Professor Jung-Min Ahn will introduce the case. Lecture.
Thank you, DW. So my case is ischemic cardiomyopathy with the multivessel disease. So the case looks like a simple, but the background scenario, background information would be very interesting and very complex. The 57-year-old female, so diabetes, non-STEMI, with heart failure, ejection fraction is 30%, originating disturbance after the brain surgery. So this is echocardiography. Ejection fraction is around 30%, some mild minimal pericardial effusion. Actually, he admitted to other hospital, and after 2 weeks after the medical stabilization, and he admitted our hospital for coronary evaluation. There is no pulmonary edema congestion after stabilization, but his coronary, it looks like this. So summarizing, ejection fraction is 30%, multiple wall motion abnormality, very diffuse, involving left main to the circumflex and irradiated diffuse coronary artery disease. So how to treat this patient? So Joo Myung Lee, could you give me some?
Okay, Dr. Joo Myung Lee. Okay, yes, and you will suggest your opinion. How would I treat this case? Is my case.
Hello, everyone. Professor Park, thank you. Professor Ahn, thank you. I'm going to suggest my opinion. So as you well know, the best medical treatment and bypass surgery shows survival benefit over medical treatment alone in this type of patient, which means heart failure with reduced ejection fraction and multiple coronary artery disease. However, revived PCI 2 trial failed to show the superiority of revascularization by PCI. However, we should consider that PCI, the effect of PCI is depend on multiple factors: duration of myocardial ischemia, acute or chronic coronary syndrome. As Dr. Ahn's case, the non-STEMI patient has an acute developed myocardial ischemia. So in this case, PCI can be done, and we can expect the effectiveness of revascularization. The second is amount of underlying microcirculation, and the third one is how to ischemia was diagnosed, non-invasive versus invasive modality, and concept of revascularization, local treatment by PCI or vessel treatment by bypass surgery. When you are considering to do PCI, we should consider local severity and distribution of coronary arteriosclerosis, especially for the diffuse disease, as we already seen by Professor Ahn's case. And if we are doing the stent implantation, procedural optimization is very important. So let me tell you about the more detail of revived PCI 2 trial. Although this trial selected the low ejection fraction and extensive coronary artery disease, however, when we compare ischemia trial and revived PCI 2 trial, you can see a striking difference in ejection fraction. However, the proportion of triple vessel disease was just same. So we should consider that revived PCI 2 trial was truly ischemic CMP or bystander coronary artery disease in another cause of depressed left ventricular ejection fraction. And this trial selected the target population based on imaging tests for the viable myocardium. However, we already know that the viability assessment is useless in our daily routine practice. Indeed, the sub-study of revived trial demonstrated that amount of viable myocardium, no association at all for the effectiveness of PCI. However, amount of non-viable myocardium or scarred myocardium had a significant association for the ineffectiveness of the PCI. So in Dr. Ahn's case, I would rather to assess amount of non-viable myocardium to find non-responder for the PCI as a revascularization. And as you well know, inducible ischemia, non-invasive stress test, it is just flip the coin. The positive likelihood ratio is only 50% for the angiostenosis or FFR positive stenosis, and ischemia trial already showed that non-invasive test-guided PCI is just same with the medical treatment. However, FFR-guided PCI had a significant prognostic benefit in terms of death or MI. And ORBITA trial demonstrated that low invasive physiologic index, higher benefit of reduction of ischemic burden. So in Dr. Ahn's case, for the circumflex and RCA region with minimal to intermediate coronary artery stenosis, I would make my decision based on the FFR. And if we are doing the PCI, image-guided optimization is life-saving treatment because we already observed the significant mortality benefit from intravascular imaging-guided optimization. Revived PCIS2 trial did not report any of the physiology-guided decision and the intravascular imaging-guided procedural optimization. So we should be very cautious about interpreting ineffectiveness of PCI from the revived PCIS2 trial. So I believe physiology-guided decision and image-based optimization is a very important treatment option for the heart failure, reduced ejection fraction, and multiple coronary artery disease. Thank you very much.
Yes. So I think a simple question, people hearing the Dr. Ahn and the Joo Myung Lee, and if this patient is a relatively young woman, if 57, and the non-STEMI, diabetics, ejection fraction 30%, and the viable test is okay, and there are many proportion is viable, what is your the option?
I would definitely do the PCI because this patient had brain tumor. Someone had a brain tumor, and we cannot recommend open the chest. That will require over 1 year to complete recovery.
Okay, we're hearing the Dr. Ahn. Thank you, Joo Myung Lee, and thank you, Tutorial Park. So even, we are very, frankly speaking, the interventional cardiologists are very hesitate to transfer patient with the low ejection fraction and complex coronary artery disease to transfer to the cardiothoracic surgeon because low ejection fraction may very high risk of pelvic surgical risk. So that's why we are trying to correct coronary artery disease by PCI nowadays in many cases. So this patient, the left main involving, so this is a diagnostic catheter. So the left main is very small. The circumflex is also very small and diffuse LAD disease. So how to treat? Actually, I need one more test. That is, we check the MRI, show that the leg cardiology enhancement is a very limited area. So full thickness impact is only the mid-anterior wall. So after the angiogram review, so here is, I think, the some portion of the full thickness MI. The other proportion is just the 25 to 50% enhancement in all other LAD territories. So traditionally, this patient classified to the viable patient. So we decide to do the PCI. After diverse evaluation, so vessel size, angiographically it looks very small, but vessel size is very big, 3.0, 4.0. Left main is almost 5.0. So we perform the balloon angioplasty first, but the balloon cannot passing through the medial LAD. So after rotabulation, we can implant the stent, long stent, and left main bifurcation stenting, and final kissing. So this is the final angiogram. It looks bigger than before, caudal view and spider view. So patient, the final IVUS evaluation showed that there is no suboptimal stent result. The before PCI, very low ejection fraction, 1 year after, the 51%. And then we also prescribed the very optimal medical treatment, including the beta blocker, Entresto, and Forxiga. So, this is a very happy story. But I think we don't know what the ischemic cardiomyopathy is, because this patient actually 2 weeks ago acute myocardial infarction ejection fraction is low. We can define it as ischemic cardiomyopathy. So another important question is that if we see the severe coronary artery disease, is it caused the LV dysfunction, or the coronary artery disease was an innocent bystander? Because the transient LV dysfunction is more frequent than the coronary artery disease caused the severe LV dysfunction. So we need the definition first. Then revascularization benefit is very limited. Previous random trial, there is no benefit of revascularization, heart trial, stitch trial. Only stitch trial, extended trial, demonstrated that the minimal reduction of survival, minimal reduction of improvement of survival. So during the 10-year follow-up, 7.5% reduction of mortality. But the BCIS, as you mentioned, the Joo Myung Lee, there is no difference. So current guideline, the bypass surgery recommended, but the PCI is not recommended by guideline. In addition, PCIS revived the PCIS 2 trial leaves many open questions. So what is viable myocardium theory? So if we found some viable myocardium, then we can improve the LV dysfunction after revascularization. So it's true for left ventricular recovery. Many non-invasive functional studies can detect the viable myocardium, but if we detected the viable myocardium, we can improve patient survival. This is a different scenario. So this idea came from this meta-analysis. This meta-analysis showed that, including the SPEC, PET, double timing echo, show that the non-viable myocardium, even after revascularization, there is no improvement in the patient survival. But only patient with the viable myocardium reduced the mortality after revascularization, 2 meta-analysis. But the stitch trial viable test study, it did not demonstrate that detecting viable myocardium is not improving the patient long-term outcomes. So current guideline did not recommend the viable test before coronary revascularization, but the revived PCIS-2 trial suggests that the myocardial scar is more important than the seeking myocardium. So I'd like to introduce our small registry studies. We included 400 patients. Ejection fraction is lower than 35%, severe coronary artery disease, performed the MRI before coronary intervention. So first, we evaluated the relationship between the myocardial scar and LV functional recovery. So large myocardial scar, less LV functional recovery. So revascularization recovered more than medication only. If a patient LV ejection fraction is more than 40% after within 1 year, increase the patient survival. But this is very interesting. Only patient under revascularization show that improved survival. If a patient on the medical treatment, even though the ejection fraction is more than 40%, the patient survival was bad. So I think the epicardial coronary artery is important. This graph is supported by our findings that after ischemic cardiomyopathy during the follow-up, ischemic event is the main cause of aggravation of ischemic cardiomyopathy. Another issue is mortality. So we evaluated many findings. So we found that the full thickness MI is associated with mortality. So we defined the patient into 2 groups, extended myocardial scar and limited myocardial scar. So only patient with limited myocardial scar after revascularization, the patient survival patient mortality is reduced by revascularization. So this is summary, the slide. In patient with limited scar, after revascularization, revascularization is associated with the improved patient survival, but the extensive scar, there is no difference between the revascularization and medical treatment. So this is an example, very extensive triple vessel disease. And this patient, the cardiac enhancement is very rare. So after bypass surgery, ejection fraction is very improved. But another case, very extensive coronary artery disease, ejection fraction is very low, extensive myocardial scar. Even after bypass surgery, improvement in ejection fraction is very limited. So this is my summary. As all patients with ischemic cardiomyopathy in which coronary disease is amenable for revascularization should be recommended coronary revascularization due to documented survival benefit from the STEMI trial. A more sensitive index for patients with a viable myocardium would be necessary to rule out patients who are unlikely to benefit from revascularization, rather than to rule in those who are likely to benefit from revascularization. So I think the conceptual change is necessary from seeking viable myocardium to non-viable scarred myocardium in revascularization decision for ischemic cardiomyopathy. So assessment of extent of myocardial scar by MRI might guide the revascularization decision and management plan in patients with ischemic cardiomyopathy. Thank you for your attention.
Thank you. So I think we have discussion time, this issue, and really important. We have a very nice heart failure medication, Forfilla, nowadays finerenone also would be available soon. And looking at the prior trial, STEMI trial is a fail. It's just we should wait 10 years to achieve the benefit. Also, the Revive the trial was failed, and I know the two trials is ongoing. One is the Stitches 3C trial, Canadian group, they comparing ischemic cardiomyopathy, PCI versus bypass surgery, and the Sculptor Bangalore is now doing ischemia HF trial, low ejection fraction less than 35, comparing PCI, bypass surgery, and OMT. And I think this would be very some most complex the real world case. Is there any comment or any opinion for ischemic cardiomyopathy?
I think both presenters have done excellent job and discussed the very important thing on the viability assessment. On top of the procedure, I have some additional comment, is to assess some minimal hemodynamic before you do PCI on those cases. For example, like the previous case, nowadays almost routinely we will check the LVN dissect pressure to assess the stability, whether you should or how you should proceed, because many of the time like this case you may end up with motivation and many complex and high-risk procedure. So if you know better assessment on the heart status by the LVN dissect pressure will be better.
I have a few comments on the first case. Given that the patient had multiple critical lesions in the three vessels, I think no doubt that we should perform revascularization for that young lady. My concern is in PCI whether we should, maybe because you have to put in a lot of stents, I would try to use physiologically guided and maybe use ECB in order to avoid probably less stents use. And for this young lady with poor EF, whether we should consider MCS support as well. So these are my comments on the first case.
Okay, comment.
I also would perform PCI, but I maybe put only one stent, mid LAD. But maybe that's enough for physiology function, I think. Maybe such a one stent could improve ejection fraction, I think.
I have one question. In your cath lab and in your practice, you gonna routinely check it up the viability test using MRI or Salem scan, or how about your practice?
Yes.
You routinely check it out, and poll, and then you get.
Well, in a patient with depressed LV, of course we will. Right now we are also having a trial. Even patients with the normal LVEF, before opening up the CTO, we want to check the viability of the muscle, whether the treatment is indicated or not. But I think for a patient with the depressed LV, we will.
Okay, so we will time limit. I'm gonna move to the next lecture, and the Professor Youngkeun Ahn. He's expert in the many STEMI trial in South Korea, and he will talking about the management strategy for STEMI with the multivessel disease. Professor Ahn.
Okay, thank you, Dr. Duk-Woo. So today I will talk about in the STEMI with the multivessel disease, how can we treat the culprit region and non-culprit region. So actually everybody knows that half of STEMI have a multivessel disease. The mortality after PCI for STEMI with multivessel disease significantly higher compared with single vessel disease. Actually, due to the several landmark clinical trials, so now it's a standard PCI strategy for STEMI with multivessel disease is complete revascularization rather than the culprit-only revascularization, mainly by reduction of new MI or repeat PCI. So 2021, the American guideline mentioned that it's preferred in the stage PCI in the non-culprit territory rather than the immediate PCI. But the immediate PCI also is acceptable. 2023, in the European guideline mentioned that it's a complete revascularization either during the index procedure or within 45 days is a class 1 indication. Actually, timing of a non-culprit PCI is immediate. Advantage is treat the secondary unstable lesions. However, in treating additional lesions might be hemodynamic and the general clinical instability can be occurred. So actually, now further work is needed to define the optimal timing of non-culprit region PCI and to evaluate the value of physiological measurement to guide the non-culprit region PCI. So actually, recent 2 major randomized control trials from the BioBask multi-stars demonstrate that non-inferior result or more superior result with immediate CR compared with stage CR. However, pitfalls of BioBask and multi-stars AMI could be observed in the long interval between culprit and non-culprit PCI. So it might be a high instance of non-fatal MI and repeat PCI in the stage group. So how to define procedure-related MI in immediate group? And no routine use of physiology and imaging guidance for assessment of non-impact rate artery. So our hospital is principal site Korea acute myocardial infarction phase 3. We are conducting option STEMI and option non-STEMI clinical trials. Actually, this is already patient recruitment was finished. Option STEMI trial is 99 patients with STEMI and multivessel disease. The non-impact rate artery with LV is 2.5 millimeter diameter and the 50% diameter stenosis. By visual estimation, the successful primary PCI for impact rate artery is the 1-to-1 randomization to immediate complete revascularization and the in-hospital stage complete revascularization. Non-impact rate artery regions with stenosis more than 75% by visual estimation without FFR, and the FFR evaluation with 50 to 69% stenosis. Actually, this is the first clinical trial in the world to comparison between the immediate and the in-stage hospital complete revascularization. So eligibility criteria, inclusion criteria is like this one, and the exclusion criteria, we exclude the cardiogenic shock at the left main disease more than 50% diameter stenosis, and also the CTO at non-impact rate artery, and the history of bypass surgery and the planned surgical revascularization. So primary endpoint is already I mentioned, and the secondary endpoint is as follows. So a sample size calculation is based on the aforementioned assumptions. We estimate 994 patients, 947 patients in each group were needed. So it is a planned subgroup analysis, it's age, the sex ratio and the Killip class, diabetes mellitus, number of disease, LV ejection fraction, LAD or non-LAD, type of P2 valve, 12 inhibitors. So actually I introduced two cases. First case is a 71 male patient. Actually this is a post-reval MI patient. So this is included in the stage CR. So subtotal occlusion in the proximal circumflex artery and the diffuse intermediate stenosis in the middle LVAD. So we performed the PCI from the OM2 to proximal circumflex artery using stenosis stent, and then the follow-up in the hospital period. So in the non-culprit region evaluation by FFR, FFR value is 0.83. So we treat this intermediate region by medically. Actually, this is case 2. It's a 6'3" male patient in the inferior ST elevation myocardial infarction. It's diffuse stenosis in the circumflex artery up to 90%, and thrombotic total occlusion in the proximal RCA. This case was included in the immediate complete revasculating group. So we immediately successful PCI in the proximal RCA, and then also successful PCI in the distal circumflex artery. So actually, trials of timing of CR in acute coronary syndrome with multivessel disease, the two studies, a randomized control trial, BioVasc, multi-stars, and they compared the immediate CR with the stage CR within 6 weeks after index procedure in the BioVasc. In the multi-stars AMI, is stage CR within 19 to 45 days after index procedure. Our clinical trial is in hospital stage CR, and also BioVasc and the multi-stars is FFR for non-impacted artery. It's just due to the operator discretion. However, in our clinical trials, all regions is 50 to 69% time stenosis by visual estimation has to be guided by FFR. Actually, it's a reliability of FFR used in acute testing is somewhat debatable, and actually acute setting during the index procedure, FFR value increased from slightly decreased from the acute to stable setting more than 2 weeks after index procedure. Actually, guideline in the acute setting of reliability FFR, invasive epicardial functional assessment non-culprit segment of the impact-related artery is not recommended during the index procedure. However, no clear guidelines exist for the FFR evaluation of the non-impact-related artery in patients with STEMI. So actually, recently, full revascularization trial was reported that they tried to complete revascularization using the FFR guidance of the non-culprit artery. However, they failed to reduce in the MACE and compare with the culprit-only revascularization. So one of the issues is that the definition of procedure-related MI, because in the detection of procedure-related MI is very difficult in patients with STEMI underwent primary PCI. So we accept the recommendation of the coronary angiography to confirm procedure-related MI in patients had new or prolonged angina within 48 hours post-PCI. So this is the network meta-analysis of randomized trials. There's no difference in the immediate CR compared with the all stage CR. However, when think about the classified into two groups, stage in hospital and the stage out of hospital. So it's immediate PCI is significantly lower MACE compared with the stage out of hospital. So considerations for revascularization in STEMI with multivessel disease, some issues are solved and determined to get some guideline. However, still, we don't know exactly how can we guide the identification region candidate to PCI in the non-culprit artery. So, and also timing also is more trials on the optimal timing of complete revascularization are warranted. So the maybe optimal timing of a CR, immediate versus in hospital versus out of hospital. FFR guided PCI for non-culprit artery in acute setting is reliable or maybe some debatable. So still we have to make a solve. So summary and the conclusion is that recent evidence, including complete trials, support CR with either immediate or staged repression in patients with STEMI and multiple. However, optimal timing of CR is still controversial. BioBask multi-star trial AMI favorable for immediate CR. In our clinical trial, probably next year, will be reported that the routine FFR guided in hospital CR can be acceptable, even between in the immediate or in stages PCI. Thank you very much for your attention.
Thank you, Professor Ahn. Any comment or any question? And Professor Ahn lecture?
May I? Yes. Well, to put a more delicate issue, you are talking about FFR detection during the acute setting, which is not standardized yet. And then to put things more complex, what about vulnerability of plaques? In the setting of acute MI or ACS, you could have a non-flow limiting lesion, which is vulnerable to have event.
I think we don't use in the imaging guide. So still, we don't know exactly it's a real vulnerable plaque or not. So I think it's maybe imaging guided PCI is one of the options, but we just think about FFR value. So might be some plaque is stable, but if we think about ST elevation myocardial infarction, probably it's non-corpusculatory plaque burden is also not so stable. It's probably the vulnerable, I think so.
So, and the prior, the BioVest multi-star AMI trial is a patient treated 2 weeks later and within 1 month, and your option STEMI trial, one group is immediately CR versus in-hospital stage CR. Can I ask a median, the duration of the stage?
I think it's maybe 4 or 5 days.
4 or 5 days.
Yeah.
Yes.
Because usually in the STEMI patient, the patient discharged within 1 week. So I think it's 3 or 5 days is a median value.
I just want to say I don't agree to discharge the STEMI case and then stage PCI, because you can see in multi-star trial, 16% case will have MACE, and STEMI and then discharge 16% patient will have MACE. That's not acceptable.
So, and the absolutely issue is about after reading the New England Journal of paper, BioBest or multi-star, the result is already expected that they included the procedure-related MI in their primary endpoint. If you're going to treat 3 or 4 days later, and the enzyme level is nearly, stabilized, and then you want to do procedure-related, some MI was much higher expected. Result is already expected. We are wondering that is really impact in the mortality and any hard endpoint that could be.
So probably maybe it's good to exclude that kind of patient. So to my clinical trial is just we can pick up the patient if somebody suffer from the chest pain but in the coronary angiogram is documented in some stent thrombosis or some event, maybe we accept the procedure related in MI, but in the other cases, it's very difficult to find out it's a real thing or not. So it's
Joo Myung, do you have any comment? You are expert in this field.
I think the BioBask and multi-stars AMI trial, we should remember that not only procedure-related MI, but also spontaneous MI, which occurred initially judged non-culprit vessel, was also higher in the staged revascularization. That means judging the culprit or non-culprit sometimes is very hard, especially in the non-STEMI patient, or even in STEMI patient, non-culprit vessel also hugely contributed the global myocardial ischemia in the patient. So I personally believe if your clinical judgment is telling you that non-culprit vessel should be treated, I think immediate or in-hospital stage PCI, so those 2 options are also okay. But the out-of-hospital stage PCI, sometimes it is dangerous. That is what we learned from BioBask and multi-stars AMI
Yeah,
trial.
I agree with your opinion.
Okay, thank you, Professor Ahn. It's a very nice lecture. Okay, we're gonna move to the master's second case, and co-moderator Dr. Kao, and about the case of a cheap PCI with limited access.
Okay, so thank you, DW. I will present to you a case of CTO chip with limited access. And these are my disclosures. We have a 33-year-old man, a young one, who had a progressive dyspnea for 9 months. And despite the best medical treatment that we can offer, he's still now in his functional class 4 status. He also had a uremia of unknown etiology, and he's under regular hemodialysis via his right forearm AV shunt. And he actually had a left arm shunt, but that shunt failed, and he actually suffered from repeated deep tissue infection over the left forearm. He had baseline hypertension, hyperlipidemia, both are under treatment, and he was a tall patient, 183, with a very tortuous aorta. And he had a BSA of 1.85 millimeter. So this is a large patient for us. And that is his ECG baseline. You can see that some QRS widening, but overall there's no major myocardial infarction in the past. And this is his chest X-ray. Obviously a large heart, pulmonary congestion, and also you can see this is a large patient with some scoliosis. And this is the picture of both his arms. So this is the right. You can see because of the shunt, he had some edema over here. And this is the left arm, really in horrible situation. So this is, again, his baseline echocardiography. You can see the ejection fraction was only 22%, and he's already on low-dose dopamine because he was admitted for ADHF. He was diuresis given and low-dose dopamine, but this is still his very poor left ventricular function at the baseline. And this is the myocardial perfusion imaging. We can see he, although some of the area is scarred, but he still had viability muscle. And this is probably the only hope that we can give him to reperfuse this myocardium. And these are his lab. You can see the BNP is markedly elevated. He had a very poor renal function, but the electrolytes were basically normal. He had a relatively low blood pressure. You can see the left ventricular end diastolic pressure was 28. He had a swan, and the wedge pressure was 27, elevated pulmonary artery pressure, and also a depressed left ventricular cardiac output, even though he's, again, on low-dose dopamine. And this is the angiogram, really nasty. You can see osteostenosis, LAD proximal occlusion. He had ipsilateral collateral epicardially from this large ramus. This is very hypoplastic RCA, but this RV branch also collateralized his LAD via this tortuous epicardial. And he had a patent lima. And also, I have to inform you that because of his height, these catheters were actually all in. So basically, there's no catheter residual outside of his body, so that we can reach his coronary with the 100 centimeters length of the catheter. So his scores, the syntax was 37.5, so high. It's not good for the PCI. Euro score 11%, also very high surgical risk. And also we calculate his chip score in case we had to do intervention. But then his chip score was also very high. Even though if we can do single access without MCS up front, it will be 7. If we have to do dual on this CTO and with the upfront MCS, then it will be 11. And also his JCTO score for the lesion itself was 2, and he had a CC score of 1, meaning that he had a large but very, very tortuous collateral. So of course we refer the patient to our surgeon, and then the surgeon turned down on the patient. Also the patient himself refused any surgery. Obviously this is a relatively young patient, doesn't want to be cut open, and the surgeon doesn't want to cut him. So this is the situation we have.
Okay, very complex case, and we will ask Dr. Yongcheol Kim how would I treat this case.
Yeah. Firstly, thanks to Kao about the very, very complicated case. This is my disclosure. This is the case summary. 43 young male patient. He complained of dyspnea for 9 months with optimal medical treatment. He had end-stage renal disease with regular hemodialysis, hypertension, dyslipidemia. Echo showed a severe airway dysfunction with global hypokinesia. Ejection fraction is about 20%. His all chambers dilated. And the MIBI scan show the ejection fraction about 15%, and there is a little myocardium viability, and the state is the diffuse bypass surgery state. And in terms of the assessed site, is right arm AV shunt state, and the left forearm got an infection prior shunt site. And the angiography showed the severe stenosis in the left main and the CTO situation in the proximal RAD, but we can see there is a visible stump and with grade 3 collateral flow from the RCA. And high score over syntax and the BCSI is chip and the Euroscore. That means it's a complicated anatomy and very complicated PCI situation and high risk of the surgery situation. So I think that is MCA support is necessary, but we have a different situation between the Korea and Taiwan. And in Korea, we is only available is the ECMO and or IABP. Impella is not available yet. So and if I were the operator, I prepare the left femoral artery and the vein access and ECMO standby. But in Taiwan, is the Impella support is available, but I was told that the only limited centers are available, and the patient should pay for the $35,000 US. And the PCI, in terms of the PCI strategy, and I selected right femoral approach as using the A French JL with the side door for the PCI for the left main to the RAD CTO. And I have no idea, but is the potentially need to the 6 French JR for the contralateral injection from the RCA, but in we only have this one access vessel for the right femoral artery. But I have no idea if we need 2 puncture site or only 1 puncture site and put the 2 guiding catheter is available or not. And firstly, I try to perform the PCI to anterograde first. If failed, is I potentially try to perform the retrograde from the RCA. Is Impella is the mandatory, but if failed, is I just have to the Amen. And IVUS guidance is mandatory. That is my PCI strategy. Thank you.
It's a very complex. People hearing the Kao's answer, any further thoughtful idea?
Ideal for impeller support and single access. Do the PCI through the impeller access.
It's a single femoral artery. You can do impeller as well as a guiding catheter.
Yes, as well as 7 French catheter, and you can use a long shift. Yeah.
Yeah, but I have the upfront use of impeller. Actually, we should remember that prospective trial was actually failed, and only the danger shock trial, obvious cardiogenic shock, impeller showed prognostic benefit. However, in this type of non-cardiogenic shock but high-risk PCI, impeller did not show any prognostic benefit over the medical treatment alone. So I think upfront use of impeller, very costly treatment. Without it, we can do it. Very cautious medical treatment, and if cardiogenic shock develop, just put the ECMO and the LV support. I think that would be sufficient.
But I think Professor Kao had done hemodynamic assessment before the procedure. You can see the wedge was very high, and also pulmonary hypertension. That could be quite dangerous if without support.
In Japan, is how would you treat this patient? Is it EF less than 20%? Is ESRD both arm cannot use?
Yes, it's a quite difficult situation. If I treat this patient, the important point is the safety procedure, needless to say. I may treat once rectal vein arterial first, and after that, the patient may recover some LV function, something, and after that, we have an option of some retrograde or something, CTO procedure. But in this situation, the LV function is quite low. The longer procedure is quite dangerous. Yes. I think so, even if the hemodynamic support is inserted. I think so.
So, and we are hearing answer is so complex patient. Okay, how do you treat?
Well, I think this case we need to do upfront, because if you start your treatment, the patient will become a danger shock patient. So I think the patient will have a cardiogenic shock if we don't get prepared. So luckily, both his femoral arteries are big enough, so we puncture both sides. We use the right for our impeller, because the right side seems to be the larger one. And the left side, we did a French puncture. So these are the only two access available. Okay, so this is the bilateral injection. We can see the same thing, LAD, left main, osteo lesion, and collaterals from epicardial. So like Dr. Lam have explained that we have a patient who cannot be cannulated both radial and brachial from the arm because of his shunt and the infection situation. He had a critical left main and the LAD CTO. So yes, maybe we can treat left main first and then see what happened. But if we want to treat them both, I think upfront MCS is needed, because his LV function is really poor, and the Swan-Ganz at the low dose dopamine showed a very poor situation. But the problem is that now we probably need two access, because this is a LAD CTO involving. So what are the other access? We can do impeller CP with single access, of course. But like Dr. Holt mentioned, maybe we can use up to a 7 French sheath with hydrophilic coating and the long one. But the problem is that this is a long patient. This is a very tall patient. So if you use this situation, you will waste some of your guide catheter length, and the guide will not reach. So if you step down to a 6, okay, maybe, but that is only for your diagnostic. So I think maybe we don't have to use both guiding, because now we have an ipsilateral collateral. You can go in and out from the same guide. So that is my plan. We just use one guide and see if we can do antegrade. If not, then we do ipsilateral retro. So this is the situation now. You can see that we have a wire in the LAD CTO segment. It looks very simple and straightforward because it's short and the distal landing zone is very clear and looks straight, but it's really difficult. So we have struggled to get into the distal true lumen, but you see somehow the wire migrate to the diagonal area, but it's not in the intravascular, and we cannot just get into the distal LAD. And we have used 40 minutes of our procedure time. Luckily, because of the impeller, the patient is very, very stable during this whole 40 minutes. So we decided to go really ipsilateral retro, and this is the advancement of the SU-003. With the support of a fine cross. So you can see with the support of the fine cross, the SU-003 can actually traverse this tortuous epicardial collateral and going into the LAD distal. You can see this is the LAD distal. And then we also advance our fine cross over these crossed SU-003. The SU-003 tip now is in the diagonal, you can see. So the microcatheter can be advanced over the SU-003, and then, of course, the rest of it is simple. We use the antegrade wire subintimally to do the reverse card, and then we can externalize this retrograde wire. And also, wiring into the ipsilateral antegrade guide is relatively easy because this was a French guiding catheter. And once we have established our wire rail, of course, we check the IVUS. just to make sure that we are not going to sacrifice the ramus or the circumflex. So luckily, everything is intraplaque. You can see these hematoma created by the antegrade wiring, but until the left main ostium, we are all true. But you can see the left main ostium is also diseased. Okay, so after this, we prepped our stent using the Zabo technique. This is still my personal favorite if we are dealing with the truly osteo lesion. So you can see a wire actually hanging the stent, and we will have a very, very precise position on the stent position on the ostium. And this is the deployment of the stent. And after that, we have a result like this. So it's all recanalized. Of course, the distal vessel is still hypoperfused, but we believe with the IVUS proving these are all true lumen, so we will just wait. And then at the end of the procedure, we close the impella wound and, of course, the left femoral. And the procedure, before the procedure, you have a wedge of 26, and at the end of the procedure, it dropped to 118, and the cardiac output increased without any change of the inotropics. The floral time and the contrast was shown here, and the patient on day 3 was discharged because his NT-proBNP dropped to less than 1500, and his condition improved significantly. And the patient was now in functional 1 status, and it's 3 months after the PCI. And you can see this is the echo just done 3 days after PCI. There's no inotropes, and the LV function already improved to 35. So we believe that the follow-up echo in a few months will be even more dramatic. So the take-home message from this case is that CTO chip is really a challenge, and proper preparation with the plan ABC is your key to success. Preemptive MCS, I think, for this patient is necessary because it gives you the patient as well as the operator comfort. And also, you should gather all the available tools and techniques because you will need them when you least suspect it. Thank you.
Thank you. Well done. And any further comment for this case?
May I have some comment? I think this is a very nice case to demonstrate trypsito, in fact, is another animal. If you look carefully on the final angiogram of Professor Kao's case, the distal AD fold seems to disappear and some burring. But beforehand, the fold is very strong due to the retrograde. It's due to the fold competition. I see it many times in those trypsito. So without support, many of the time you open the vessel and then fold competition, and then the patient will crush, despite you have some very successful and smooth procedure. That's something we learned from previous experience.
I think it's a very excellent procedure for radial approach. But I think one option, or single guide catheter, chip detection on ADR is one option. It's a very good option at that case. ADR.
Okay, Michael.
Just a couple of thoughts. Number one, in a patient with a wedge of 28, I probably would have volume optimized them better. I probably would have done aggressive dialysis to get their EDP lower. Number two, the low-dose dopa, if you think about it, let's say 1 to 3 mics per kg per minute, that's really kind of a renal dose dopa, has more of a vasodilatory effect on the splanchnic arteries. So if you want to go to a higher dose, let's say 5 to 8 mics, that's more of the kind of inotropic effect. So I think the low-dose dopa doesn't really have much of an inotropic effect. If you think about SOAP2 trial, there's no benefit with dopamine in cardiogenic shock. It was beneficial in septic shock. The agent that was beneficial was norepinephrine. So I would say the preferred inotropic agent for cardiogenic shock would be norepinephrine.
Yeah, agree. Well, the patient is not in shock status though. So he was on a very strong diuretics with the help of low-dose dopamine. But I agree that if we can lower the wedge pressure lower, maybe the patient will be more comfortable. But the problem is that how do we get ourselves through the procedure, I think. So I think MCS in this case is still necessary.
Dr. Kao, how can you deal with this patient in the Korea situation without the implant?
I know, it's very difficult. So maybe you should appeal to your government.
That's why I'm telling you that actually non-cardiogenic shock patient, but preventive impeller use has no supporting evidence at all. Up to date, actually, the previous trial failed to show prognostic benefit of preventive use of impeller for high-risk PCI. In Korea, without impeller, we are treating this type of patient even without impeller.
Yeah, just to build on that, your answer is true. In the PROTECT 2 trial, the 30-day endpoint showed no benefit with intention to treat, but per protocol at 90 days, there was a benefit with preemptive MCS with impella. So, you know, it's two sides. Primary endpoint, a priori, no, but per protocol at 90 days, yes.
Yeah. No, like I've shown in my last slide, I mean, impeller give you comfort and also give you confidence so that you can do a more complete revascularization. So I think the benefit at 90 days for the PROTECT 2 is probably due to the more complete revascularization. I think the discussion point on this patient is that, well, this is not a cardiogenic shock patient to begin with, so it will be considered a preemptive MCS instead of a cardiogenic shock MCS. But like I said, if you do the case without the impeller, the first minute the patient will become a danger shock patient because the patient will crash. Once you have a device in your coronary, the flow gets slower, the patient will crash. Of course, at that moment, you will put in an impeller in a hasty fashion, and then you will have vascular complication.
Great. So, and due to time limit, and we're gonna move to the last lecture, and Professor Junior Ako, and he gonna very important lecture summarizing all session is hemodynamic support in AMI cardiogenic shock. Okay, Professor Ako.
Thank you very much. Thank you for the introduction. My name is Jun Eko from Kitasato University. So my talk is about use of impeller in AMI cardiogenic shock patients. So it's a little bit different from the chip that you've been talking about, but this is my disclosure. So cardiogenic shock in AMI is a different animal. So for patients with KIRIP 1, 2, 3, those in AMI patients, primary PCI showed very good results in this Japanese registry showing single-digit mortality in hospital. But as for KIRIP 4 AMI patients, it's associated with very high risk of mortality. So we have different modes of MCS in this clinical settings. So IABP, impeller, and tandem heart, and VA ECMO. So VA ECMO is frequently used in Japan, but now we have impeller in our hands. It has significant difference between VA ECMO versus impeller. For patients receiving VA ECMO, it shows a high risk of high afterload, while impeller reduces the afterload. And for LV-EDP, there's a significant reduction in use of impeller. So previous clinical trials using MCS in cardiogenic shock situation show no benefit, whether it's IABP or ECLS shock with the use of VA ECMO. But now, as you can see, we have danger shock trial, which included 360 patients randomized either to impeller CP plus guideline-driven treatment versus guideline-driven treatment. It took more than 10 years to finalize this clinical trials. So in this clinical trial, many patients are very sick patients. More than 70% had LAD or left main MI, and LVEF about 25%, and median lactate 4.5. So very sick patients were included in this clinical trial. And now, as you know, this danger shock trial has shown a clinical benefit in 180 days mortality with the NNT of 8. So that means with use of impeller, you can save 1 in 8 patients as compared with previous guideline-directed therapy. And as for subgroups, there's no interaction between those important subgroups. But it comes with a price. The renal replacement therapy was we see more renal replacement therapy needed in patients who received Impera. But in survived patients at 6 months, every patient are out of this renal replacement therapy. So let me go through some of the Japanese data. So Impera was introduced in Japanese market in 2016. It's improved in 2016. Now we have more than 10,000 cases, and every case is registered to JPVAD registry. So best practice was implemented in Japan, and we learned from NCSI, which is a US registry, and EU registries as well. And Impera best practices included early identification of cardiogenic shock and pre-PCI Impera initiation. And use of pulmonary artery catheter was stressed. So, as I said, more than 10,000 cases are registered in this registry, but I'll show first cases, first 1,300 cases in this paper. So among all the cases, AMI cardiogenic shock was about 600 cases. So those cases, so it's not a randomized trial. So we compare those cases, Impera alone versus Impera plus ECMO, ECPERA cases. So this is the patient characteristics. And in danger shock trial, out of hospital or in-hospital cardiac arrest cases were excluded. But in this registry, we have about 30% of the cases had out of hospital cardiac arrest, which was included more in ECPERA cases. And about 80% was STEMI, and left main was about 40%. And Impera support pre-PCI was down in about 66% of patients. And this is a 30-day survival shown here. For the patients with ECPERA, which included more sicker patients, the mortality or survival rate was about half. But about Impera alone cases, we have seen a 30-day mortality of 80%, 30-day survival of 80%, which is significantly better than the previous registry data. So this is ejection fraction at the pre-implant versus explant. Impera alone patients showed increase from 35 to 44. For ECPERA patients, from 25 to 44. So major adverse events are shown here. I'm afraid there might be a case for underreporting, but we have seen hemorrhage and hemolysis are the main adverse events in this registry. So what's associated with the survival? From shock to shock diagnosis to Impera less than 6 hours. So the earlier Impera were associated with better clinical outcome in this registry. So now clinical guidelines in Japan, the use of Impera was approved for stage C and even for stage B shock patients. Now, Impera may provide a novel early unloading approach in acute myocardial infarction patients, even without shock. So this is a swine model of myocardial infarction. So the peaks were randomized either to the early revascularization in this group versus 60-minute wait with Impera CP on, and then revascularized. So in this Impera CP supported weight swines showed better less myocardial infarct size. So now in United States, they are doing a STEMI DTU trial. So in this trial, so this is a pilot trial, but in STEMI DTU randomized trial, the LAD MI were included. And in one arm, Impella CP was implanted and 30-minute wait. And then revascularized those patients versus standard primary PCI in the control arm. Now, I think that these results will be presented next year, I think. So in conclusion, AMI cardiogenic shock is associated with very poor clinical outcomes. Danger shock randomized trial has shown mortality benefit with Impella in AMI cardiogenic shock patients. JPVAT registry has shown excellent results of Impella in a real-world setting, and STEMI DTU may prove a novel mechanism for myocardial protection by LV unloading by Impella in STEM patients. Thank you very much for your attention.
Any comment or question? I think this is a very, interactive session. Any comment? So my question is about you mentioned danger shock trial nearly in Norman took a decade from their initial idea, completion of the trial. So looking at the use of Impella, and as you mentioned in the Paul, your case, Impella use much common in the chip procedure, low ejection fraction. So I'm the asker that the Dr. Junko and the other panel is do we need additional trial targeting AMI without shot as well as a chip patient, low ejection fraction for random trial? We didn't have any supporting evidence, but we do in our practice. How do you think about it?
I think we need more clinical trial using Impella. Actually, in Japan, it's not approved for high-risk PCI. It's funny. It's only approved for shock patients. Yeah, so.
But how about reimbursement for if you're going to...
It's fully reimbursed.
Even in the chip population.
May I share my experience? My comment is that Impella slightly improved the outcome in cardiogenic, just slightly. But Impella significantly improved the outcome of ECMO patient because after doing routine Impella, we found that the outcome is much better than isolated ECMO.
Yeah.
I think that's related to the unloading of the left ventricle, because if you have a failing left ventricle and you put on ECMO, the LV and left atrium will balloon, so to speak. So I think the idea of time to unload is very critical. I think in the setting of acute myocardial infarction, the unloading is one issue. The other issue is to prevent reperfusion injury, because we know that we are all looking for D2B, but now we are reaching a plateau. Even we can recanalize in 10 minutes, still we don't get that survival benefit additionally. So I think unloading and also prevention of reperfusion injury is probably the focus.
And I think that in danger shock trial, the curves are diverging. So I think restoring the LV function may play a role.
But we also have to reduce the vascular complication and also the hemolysis.
I would like to also highlight the difference between AMI cardiogenic shock and clinical elective trip case. In elective trip case, you can do more hemodynamic assessment. But in short case, you can see from the danger trial, just let the EF and BP, that's enough. Probably at LVN dissect pressure. But you may not need a full hemodynamic assessment for AMI.
Michael, how about the pattern in the Impella used in US? Chip patient is a preemptive Impella is very common?
It depends on who. I think it's operator dependent. I think there's regional variations. Unfortunately, in the United States, a lot of behavior is incentivized financially. And when you have that aspect involved, people are going to use it and they can justify its use based upon clinical trials. But I think it takes a lot of clinical judgment and experience. If you have a distal left main, ejection fractions 30%, And it's very straightforward. Your hemodynamics are good, your cardiac power output's fine, your EDP is 12, straightforward, no problem. But if you have a very complex left main, requires atherectomy, last remaining vessel, so there's clinical and judgment involved. Similarly for acute MI, we have oftentimes people come in with acute MI with blood pressures in the 90s, so they meet the criteria for danger shock, right? But you take a look at the angiogram, it's a mid-LAD, there's no side branch, you get it open quickly, they may have some bit of hypotension, require some inotropes, no problem. But those patients in the ER with the blood pressure of 50, and you gotta start norepinephrine, dopamine, they get to the cath lab, the blood pressure is still 70, at that point, you need to settle down, put your Impella, take your time. But there are times, so it's just all about clinical judgment, assessing the patient, and then making your judgments based upon a clinical experience.
Yeah. Good, great. Okay, thank you. Thank you, very nice lecture. So we're gonna finish this lecture the next day, and a very diverse live case is prepared. We're gonna start 9 a.m. tomorrow morning. Okay, thank you for your attention. Yeah, I think this session is a very